Okay. Well, we're sitting here with Dr. Brian Annex, who's the George Beller Distinguished Professor and Chief of Cardiology at the University of Virginia, and an expert in angiogenesis and peripheral arterial disease. And I'm interested, Brian, first of all, thank you for an excellent grand rounds today. I think we all enjoyed hearing about medical treatment of peripheral arterial disease, and then your most recent insights into the mechanisms of peripheral arterial disease and potential therapeutic avenues of that research. One question I have for you is, what got you into this arena? Tell us the story. How did you get into peripheral arterial disease, angiogenesis?
I was trained as a coronary interventional cardiologist, had an idea of doing translational research, got exposed to the delivery of these agents in early human trials, vascular endothelial growth factor and other proteins, and it became very clear to me that there was the clinical world and then there was the basic science world, and the two were not talking to each other. So we used that as our avenue to get started. But we moved into the area of peripheral arterial disease for a couple of reasons. One, it was a lot easier to study than coronary artery disease. Second, I was not a peripheral interventionalist. So therefore, I was more in between a lot of the different camps of managing peripheral arterial disease and could be somewhat, agnostic to the different approaches. And I think it allowed me to have the ability to interact with a lot of different groups. And fortunately, a combination of luck and a bunch of other things all worked out. I remember going to my division chief and asking for about a month off so I could get some grants in, and figured this was my last shot to get them, and fortunately they all got funded and did well. But it remains a huge clinical problem. That's what I'm so impressed by is it's embarrassing to some degree when we read coronary artery disease and we can look at every single perturbation is studied, there's data for it, and in peripheral arterial disease we continue to struggle to try to advance things. So I think we're always looking at different strategies that we can bring in, evaluate safely, and try to move forward.
Alan Lumsden, of course, is coming from a different perspective as a vascular surgeon, and Alan, tell us what you think about the involvement of cardiologists in this area and what we're contributing, working together in peripheral arterial disease.
So as you know, John, one of the things we really pride ourselves here is the integration that takes place between the Department of Surgery, Department of CV Sciences, and the Department of Cardiology. We don't have any issues. And part of that is because I think everybody's doing the right thing. I think that issues arise when one group, I'm not saying we're right or they're wrong, but one group perceives the other group are doing the wrong thing.
Right.
And I think that that's one of the real challenges. We have absolutely no problem working with anybody if we're all kind of marching in the same direction. And now as a leader, of a division or department, you got those challenges of how do you control that? And so we've been very fortunate, and that's really not been an issue. And so as I travel around the country, I'm often regarded with suspicion by my vascular surgery colleagues because say, we love the cardiology, we work with them, we work with the heart surgeons, and they're like, well, how can you possibly do that? And so because of this, I think that we don't have what we'd call crazy things being done, and if there are, we talk about them and we listen to one another. And so I think cardiology has an immense amount to bring to this. Nobody does clinical trials better than cardiology. And what has been, and so the challenge for us, I'd say, is we have to make a decision on grandma today. What's the best way of treating her in my hands today? And I think we do that very well. What cardiology has done better than any group is to say, how do we move the ball forward in population trials? And you've been in the forefront of doing a lot of these procedures.
Well, Alan, as you know, we were involved together in a lot of the early trials, and I think one of the what was done probably 10 years ago, where we had cardiology and vascular surgery completely partnered on clinical trials. Unfortunately, that's not been sustained. And I don't think that does anybody any good, because I think different groups have a lot to add. And as you said, as long as what you're doing is reasonable and can be evaluated and can be studied, I think it's the teams are going to advance this, not individuals. And I think we have to continue to look at ways to do that. And fortunately, at our institution, we have the same thing. We have a terrific working relationship with vascular surgery and interventional radiology. And we're constantly talking about ways to, how do we go to a service line approach? And the service line approach is not simply for the clinical care, but also how do we recognize the clinical problems, and how do we come up with ways to address them and move the field forward.
Can I ask you one question? And one of the things that we're very proud of is the imaging. And this, to me, is part of the power of what we do, is that we have our own imaging in the heart center, the MRs, the CTs, the ultrasound, the nuclear. And I have to be a little careful since this is going to be out in the public domain, but the difference between talking to a clinician who's vested in imaging versus an imager is transformational, in my opinion. Your thoughts?
I think you are 100% correct. And there is a very big difference between, again, if you move out of the PAD area but into the general cardiology area, I think there's a difference between those who can read echoes and your real echocardiographers. And, I actually tell everybody on rounds, I don't read echoes. I don't have the, I can look at them and I can see what's there. I think it's a matter of expertise, and it's a matter of understanding and learning what you know and what you don't know. We fortunately at UVA have also a terrific program with with our radiology, where all of our imaging is shared. So we work together very well on that, but I do know it's a problem elsewhere.
One thing you just said that struck a chord is that when you really understand a disease or technology, you really appreciate the subtleties of it.
Absolutely.
Peripheral arterial disease is more than just claudication or more than just critical limb ischemia. Each of these individuals is quite different in their anatomy and their physiology, their adaptation to their disease. It's a lot of exciting things there to investigate. But there is these two different types of peripheral arterial disease broadly that you talked about. There's patients with intermittent claudication, and there's patients with critical limb ischemia. And I thought some of your comments today about the genetic differences between individuals in their response to occlusions in their arteries can lead one patient to develop intermittent claudication, another patient to develop an ischemic ulceration, gangrene. Maybe talk a little bit about that difference between the genetic difference between the patient with intermittent claudication and the patient with critical limb ischemia.
Yeah, it's interesting. By way of background on this, we actually use the observation from the heart failure area. There are plenty of patients with heart failure with ejection fractions of 15% who are doing totally fine, and some with ejection fractions of 40, 45% who are horribly disabled. And so it shouldn't surprise us, yet somehow for PAD that has never quite been appreciated. I think one of the big issues has been this reliance on having reproducible leg or buttock pain with walking that's relieved by rest to be diagnosed with PAD, which is often done. If we took the same analogy for coronary artery disease, we would only require mid-sternal chest pain brought on by exertion that's relieved by rest. Well, we would be missing 3/4 of the coronary population. So I think there are simple things there that we can do. But at the end of the day, you are 100% right. There's one big problem, which is why does atherosclerosis go to the lower extremity? And why does it affect that area? And the second is, what's the body's response when an occlusion occurs? Whether that's near complete or total occlusion, which happens in most patients. And I think we're just beginning to understand them. I think we've tried to apply things from coronary artery disease and assume that they're going to work in peripheral arterial disease. And and when you listen to vascular surgeons, they're very clear that these are two very different diseases with very different blood flow patterns. And again, to first-year medical students, it shouldn't be surprising, right? The heart fills during diastole and the leg during systole. And why we don't even think of them as different is kind of interesting.
So when we do interventions, we do it to improve blood flow, but we don't measure blood flow.
That's correct.
And any thoughts on that?
Well, I think some of it is that we don't, some of it has been a technology issue, and I think like anything, technology is going to get better. Blood flow to the leg, again, Chris Kramer taught me most of this. Blood flow to the leg is so low at baseline that it's very hard to get a signal to noise ratio that you can believe. So you have to do something to augment flow. We can either use a vasodilator, cuff occlusion, or a foot pedal in the MR scanner to maximize blood flow. That's what Chris does and has been studying those different effects. But I think at the end of the day, this paper, one of the papers that I highlighted, that showed that when you completely normalized a single inflow lesion, you do not automatically improve muscle perfusion, is a very real problem. In the heart, it's a little easier because, again, heart has so much higher blood flow and perfusion that it's more easy to measure. But I think ultimately we're going to have to understand that, and have to understand that mice are mice and humans are humans. And the blood vessels that will ligate in a mouse are about the size of the collateral blood vessels that we're dealing with in patients. So there's a big scale issue.
Alan's point about not measuring limb blood flow clinically after surgery or after an intervention is an important one, because certainly that is a determinant of the benefit that's achieved with an intervention. That being said, there are a fair number of studies, including work that we've done, that the limb hemodynamics are not very predictive of a functional performance.
Absolutely, yeah.
So your ability to walk on a treadmill doesn't really correlate well with ankle brachial index, doesn't correlate well with muscle or calf blood flow with plethysmography. There's a correlation, but it's very rough and it's weak. It's a weak correlation. So there clearly there's other adaptations to ischemia that are occurring in the skeletal muscle that we don't really understand. But your work with the two strains of mice, the BALB-C and the C57, may provide some clues as to what are maybe the adaptations that occur with ischemia that allow some people to walk farther.
Right.
Some people, on the other hand, will develop critical limb ischemia and gangrene.
And at the end of the day, we measure, the most frequent clinical measure is the ABI, and there's no doubt for surgical interventions and some catheter-based ones, there's some predictive value, but that's measuring flow. It's not measuring perfusion, and the two are very different. And I still think we have a very poor understanding of blood hitting a certain vessel diameter, and that blood vessel communicating with the skeletal muscle to actually deliver oxygen and remove toxins. And at the end of the day, if you don't do that, it doesn't really matter how much blood flow you get if there really is not that precise vascular connections. And I think that we, for ease and Probably for generalities it works. I think there's very little doubt that if you take a group of 1,000 people with an ankle brachial blood pressure index of 0.9, they're a little bit better than the group with 0.3. But the fact is, for every individual person, it's completely irrelevant. You can have patients with critical limb ischemia who have ABIs of 0.6, 0.5, and you can have claudication patients with ABIs that are unmeasurable. And yet somehow we've not used that or sought to investigate that clinically.
Yeah. I'm going to let Alan have the last question.
Last question. I got to choose a hard one. I think we'd all agree that molecular and cellular strategies have been pretty disappointing so far. So you're in the forefront, John's in the forefront of this. Next 5 years, something going to come to clinical reality?
Will something be approved within the next 5 years? Probably not, but my hope is that we will, I think we need to change the approach that we're taking. And it is just unfortunate that we continue to do clinical trials in the same way that we've been doing this. And I would pose, and I could turn out to be very much wrong. We'll see when our data gets unblinded. But our hypothesis is that we can get a much tighter measure on skeletal muscle perfusion. And if we can, then we can do clinical trials on a much more targeted way to see if a drug works. We've all seen this. Unfortunately, everybody does the same CLI trial and the same claudication trial, and they get surprised when the small numbers don't get replicated in larger studies. Everybody thinks if you have a signal in a small study, it's because you got a huge effect and you're just missing, and it'll be great when you go to larger people. The problem is with smaller trials, you're just as likely to see a random signal for no good reason. So I think that's the next
skeletal muscle signal. If you were to hang your hat on the skeletal muscle perfusion measurement, what's it going to be?
I think it will be MR based. That's what and again, this is not generalizable right now, and I may be changing my tune in June when we analyze the data, but if we're correct, if a typical walking study is going to require something around 150 patients for a 2-arm, or 100 to 150, we could probably get away with closer to 20 per arm. So we'll see.
Well,
Stay
in closing,
tuned.
I would say that no one I know that has done it better than you in translating the
kind.
basic research insights through animal models of peripheral arterial disease into the clinic, testing new therapies in patients with peripheral arterial disease. You've done very well, and you've contributed a lot to the field. And looking forward to see how these new basic research insights that you talked about today will be translated by you toward new therapeutic avenues. Thanks so much, Brian, for joining us today.
Thank you for having me. It's been a lot of fun.
Thanks, Brian.
All right.